Welcome everyone to today's Better Hearing webinar. Today we are going to go through essentially Audiology 101 and talk about hearing loss and various treatment options. I'm Caitlyn Whitson. I'm a faculty audiologist at the UNC Hearing and Communication Center. Today I'm joined by Zachary LaBarth, and we will be discussing hearing loss and treatment options. Zachary comes to us from Salus University in Pennsylvania. He received his bachelor's degree in communication sciences and disorders, as well as in public health. He enjoys working with the military population, and after he graduates from his doctoral program at Salus University next May, he hopes to work at a VA with veteran population. He currently enjoys exploring the many hiking trails that North Carolina has to offer. And we all know here that we have lots of those available. So Zachary works as our fourth-year doctoral extern, and he will for the next year until about April or May. So at this point, I'm going to switch over to Zachary, and he is going to talk for the first half of this presentation.
All right, thank you very much, Dr. Whitson, and hello, everybody. Glad to be here with you all. I really hope that you learn a lot from today's topic, and I'm excited to share it with you. For those of you who are not familiar with our practice, the UNC Hearing and Communication Center is a nonprofit practice with a faculty of all doctors of audiology. This is a training clinic for doctoral students of audiology, including myself. At our clinic, we do adult diagnostics, hearing aids, as well as discuss and provide hearing protection options. We work with all hearing aid manufacturers, which is something that we're very proud of. At our clinic, we do have an unbundled fee-for-service business model. So everything is priced out separately, which makes it easier for the patient. We also offer vestibular imbalance testing as well as tinnitus specialty testing. We do have 3 locations. The main clinic is located at 6015 Farrington Road, which many of you have been to. The other 2 locations are located at the Seymour Center as well as the Orange County Sportsplex in Hillsborough. If you would like to make an appointment at any of these locations, you can go to our website at unchcc@med.unc.edu, or you can always give us a call at the number provided below. If you are watching this live, I encourage you to go to our Facebook page at facebook.com/UNCHCC. You can find all of our recording webinars there. And if you are watching this on YouTube, we hope that you press subscribe and like us and watch our videos going forward. All right, so today's agenda, as I mentioned, the topic today is Audiology 101, and these are the topics that we will be covering. All right. This image is one that you may have seen before, but I would like to review again the different parts of the ear and highlight each part of the ear's role in the transmission of sound as it enters into the auditory system. The first portion of the ear we'll talk about is the outer ear, which is the visible part of the ear, the part that we see every day on the side of our head. The part that we're pointing at right now with the laser pointer is what we call the pinna. The pinna is the part of the ear that has grooves and ridges that provide a natural volume boost for the frequencies that are necessary for speech perception, specifically those that involved with hearing consonants, which are important for the distinction and clarity of speech. It also allows for sound localization, which helps us determine where sound is coming from. The second portion of the outer ear that we'll discuss today is the ear canal. This area also helps provide boosts to the sounds that we hear, as they enter into the ear and travel through the brain. Moving to the second part of the ear, the middle ear, the eardrum, which is located, we're pointing at right now. As sound enters into the ear, sound vibrates the eardrum. That sound signal then moves the three little bones in the middle ear called the ossicles. And a fun fact about the ossicles, they are the three smallest bones in the body. The ossicles form the bridge that connect the middle ear and the inner ear, allowing sound to travel into what is the snail-like structure called the cochlea. The last portion of the middle ear that we will discuss is the eustachian tube. Because the middle ear is enclosed in the bones of our skull, the eustachian tube allows for air to travel in and out of the ear and also equalizes pressure within the middle ear. Moving from the middle ear to the structures of the inner ear, the two main structures in the inner ear are the cochlea, as mentioned before, and the semicircular canals. The cochlea is responsible for hearing, and the semicircular canals are responsible for balance. Today, we're going to stay focused on the cochlea, however. The cochlea is a fluid-filled structure, and it changes the mechanical vibrations from sound as it comes from the eardrum and the ossicles into electrical impulses. The cochlea is arranged by frequency, much like a piano, and encodes sounds from 20 hertz, which is a low-pitch sound, to 20,000 hertz, which is a high-pitch sound in the human ear. Hair cells bend in the cochlea as the fluid is disrupted by the mechanical vibrations or sound waves. These mechanical vibrations are interpreted by the hair cells as signals that are sent up to the brain by way of the auditory nerve and interpreted by our brain as sound. The types of hearing loss. Type of hearing loss is how is determined by the location of the impairment. There are three types of hearing loss. They are sensory neural, which involves the inner ear or the auditory nerve. Conductive hearing loss, which involves the outer or middle ear. Or a mixed hearing loss, which is a combination of the two. So it's the inner ear as well as the middle and outer ear. The type of hearing loss influences the treatment recommendation, which is what we're going to move forward and talk about now. Sensory neural hearing loss is almost always permanent. Typically, it is gradual, but in some rare cases, it can be sudden or acute. In adults, sensory neural hearing loss can be caused by aging as well as prolonged exposure to loud noise. In children and infants, sensory neural hearing loss can be caused by congenital abnormalities or infections. In this type of hearing loss, higher pitched tones may sound muffled. It may be also difficult to pick out words in the presence of background noise. Other causes of sensory neural hearing loss include an acoustic neuroma, which is a benign tumor that grows on the auditory nerve, or auditory neuropathy, which is when the hair cells are functioning normally, but there's a problem with as the sound goes up the auditory nerve into the brain. In severe cases with the sensory neural loss, hearing aids can be limited, which is why we're going to talk about some other options for hearing loss later on in today's presentation. Taking a closer look at one of the components that is responsible for the way we perceive sound, here we are looking at an up-close image of the hair cells that are located in that snail-like structure called the cochlea. The image on the left is one that shows normal hair cells. These hair cells are well organized, healthy, and moving together. When an auditory signal enters into the cochlea and stimulates the hair cells, the signal is sent to the brain and is strong and robust. The image on the right is the opposite. Here we see many of the hair cells have broken off and are no longer present or organized. When the auditory signal enters into the cochlea and stimulates the hair cells or lack thereof in this image, the signal that is then sent to the brain is not as strong, making it more difficult to not only hear but understand the sounds that are being heard. Other times, the hair cells are not damaged, however, the damage is to the auditory nerve. Damage to the hair cells is far more common and is typically what we discuss when we talk about sensorineural hearing loss. However, damage to the nerve does occur. If there is a problem with the auditory nerve, you would know about it and you would have been referred to an ENT for further evaluation. The second type of hearing loss we're going to discuss further is the conductive hearing loss. This occurs when sound is not reaching the inner ear due to a blockage or mechanical breakdown in the transmission of sound through the auditory system. In other words, the underlying organ of hearing, the cochlea, is normal and healthy, but the sound cannot reach it. Something as simple as a buildup of earwax can cut off sound and create a temporary conductive hearing loss. Other causes of conductive hearing loss can be more serious, such as an ear infection or various types of middle ear disorders, including otosclerosis. In most cases, a conductive hearing loss can be treated with medicine or surgery. Conductive hearing loss accounts for about 5 to 15% of all hearing losses. Other examples include a perforation of the eardrum, which is a hole, ear infections, eustachian tube dysfunction, which is a problem with the equalization of pressure in the middle ear, and as mentioned, otosclerosis, which is a growth that goes around the little tiny bones called the ossicles in the middle ear. The last hearing loss we'll discuss is the mixed hearing loss, which again has elements of both a conductive and a sensorineural loss. So there's damage to both the outer, middle, and inner portion of the ear. An example of this could be age-related hearing loss and an active middle ear infection. So the sound is having a hard time getting into the ear, but once it does, the signal going up to the brain is also not as strong and robust. So now that we've talked about different types of hearing loss, we want to say, what are our treatment options? All right, so first things first. You should always have a comprehensive hearing evaluation before consulting anyone about treatment options for your hearing loss. During a typical evaluation, some or all of the tests up on the slide will be completed to help accurately assess your specific type of hearing loss. During an evaluation, we are looking at your ability to detect, discriminate, as well as process sound. Some testing will be completed only when deemed medically necessary. At the conclusion of your test, your results should be explained to you, and it should be decided if there is an indication that you need medical intervention, and if so, you would be referred to an ENT. Most of the patients we see that come into the clinic have age or noise-induced hearing loss, and medical intervention is not indicated in those cases. Some of the devices that we'll talk about today require referral and evaluation by a certified ENT due to the surgical procedure that is involved in the implantation of these devices. Treatment options for sensorineural hearing loss. The most typical treatment options for sensorineural hearing loss are hearing aids or a cochlear implant. Hearing aids are appropriate for those who have good speech discrimination when the volume of what's around them is increased or the words around them are increased. These devices are typically useful for hearing losses that range anywhere from a mild hearing loss all the way to a severe hearing loss. However, once speech discrimination drops and the patient no longer receives benefit from the hearing aid, a cochlear implant may be the more appropriate option. A cochlear implant allows for better hearing for more severe hearing losses, ranging from moderately severe to profound. For conductive hearing losses, it can be temporary or it can be permanent. Most people with a mild to moderate conductive hearing loss choose not to proceed with any type of intervention, and they choose to monitor their hearing loss. For most, it's not bad to do anything, and that monitoring is the best course of action. Some, depending on the severity, may choose surgery as their treatment option. Others will choose to get a hearing aid depending on the person's need and lifestyle. And finally, treatment options for mixed hearing loss. People with mixed hearing loss are less likely to only monitor their hearing loss, as they tend to have they notice a greater severity in the difficulty hearing than what would be normally seen in a conductive hearing loss. Sometimes a conductive loss can progress over time, making medical intervention or surgical intervention necessary. Treatment interventions for a mixed hearing loss can be similar to those that we discussed on the last slide. Now we're going to transition and talk a little bit more about hearing aids. Hearing aids can be prescribed for a variety of hearing loss types, severities, and causes. What does a hearing aid do? Breaking it down, a microphone picks up the sound and converts the sound into an electrical or digital signal. An amplifier then increases the strength of that signal. In prescription-based hearing aids, the signal is manipulated by advanced signal processing before sending the sound to the receiver, which is the portion of the hearing aid that's located within the ear. If you follow along with the laser, you can see how it progresses from over the ear, and the receiver is encased inside the ear. The receiver or speaker then converts that signal back into sound and sends it into the inner ear. The brain hears and understands this signal or sound as speech. As you just saw, hearing aids amplify the sound going into the hearing aid. This amplification of sound then triggers the neighboring hair cells located in the cochlea to help out the hair cells that are damaged or weakened. Additionally, hearing aids also help filter sound, allowing you to focus on the words being said to you and cutting out the background noise that might be distracting or allowing you not to hear what is being said to you as clearly. Basically, it makes it easier for the brain to process sound. Where can I buy hearing aids? There are several individuals and places where you can buy hearing aids from. First and foremost, you can get your hearing aids from a doctor of audiology or an audiologist. Audiologists have training that lasts 8 years. Audiologists work in clinics, ENTs, universities such as UNC, and hospitals, including UNC Hospital or the VA Hospital. The training an audiologist goes through is more than just hearing aids, however. Myself and the audiologists at UNC HCC use diagnostics, technology, and the utilization of communication strategies based on extensive knowledge and best practice to develop the best treatment plan for you. Other options when buying hearing aids, you can go to a hearing aid dealer, which is mostly found in retail stores. The training is not as extensive, and hearing aid dealers are only allowed to work with adults, whereas audiologists have the ability to work with adults and children. Other options for purchasing hearing aids is online or over the counter. All right. So where do you start when selecting a hearing aid? It's important to not only know what type of hearing loss you have, but what technology best suits the lifestyle you live with your hearing loss. A hearing aid should provide proper amplification. It should fit comfortably for 8 or more hours a day. It should be easy to put on and stay on well, so it should fit well. It should be compatible with any assistive devices you have, whether that be your phone, TV, whatever it can connect to make it easier for you to use. It should also fit into your budget. Not all top of the line hearing aids fit every lifestyle. So it's important for us to determine your lifestyle and pick the hearing aid that's best for you. Hearing aids now have options for rechargeable, Bluetooth compatibility, as well as features that allow for better management of picking up sound and voices with the presence of background noise. There are several types of hearing aids, some that fit in the ear that range in several sizes, others that fit over the ear that can also be smaller or bigger depending on the severity and type of the patient's hearing loss. Finally, the hearing aid option that we'll discuss is one called a cross or a bicross, which is used primarily for single-sided deafness. So one ear is good and the other one is not good. Cross stands for contralateral routing of signals, and bicross stands for the bilateral contralateral routing of signals. Essentially, it looks like you're wearing a hearing aid on both sides. However, one hearing aid takes the sound and picks it up and transmits it to the better ear. This is needed when one of the ears is so bad that it does not benefit from a hearing aid. A bicross, however, is similar. However, the good ear also has some type of hearing loss or severity of hearing loss and also receives amplification. So it has a transmitter that sends the signal from the bad ear to the good ear, and it also amplifies the signal that's coming into the good ear. With that, I'm going to swing it back to Dr. Whitson, who's going to talk about realistic expectations and another type of treatment option, cochlear implants.
All right, thank you for that, Zach. So we're going to go over a few more things today while we have you all here. Thank you for sticking with us. So it's one thing I spend a lot of time talking about with patients in the clinic here is what you can really expect from hearing aids. And when I go into a consultation with people to talk about hearing aids, it's really apparent that some people have unrealistic expectations for what to expect from a hearing aid. And it's natural to have that because a lot of people don't really have a lot of knowledge of what to expect. They think, oh, I'll get a hearing aid and I'll be able to hear well. So some unreasonable expectations are that a hearing aid is going to restore normal hearing abilities and it's going to be a miracle fit, basically. No hearing aid is that perfect. We can't regrow the hair cells in the inner ear. And so we're always routing sound through a system that has damage. People expect the hearing aid's going to have true high fidelity sound or be just as good as my noise canceling headphones. Well, noise canceling headphones completely block your ear and block out all sound physically. A hearing aid is not blocking your ear, nor would you want it to. It would sound pretty unnatural to listen to the world through plugged ears. People expect hearing aids to have absolutely no feedback ever in any situation, and that's just not the case typically. They want to have perfect speech understanding in perfect communication in all environments, and not even people with normal hearing really have that ability. Some people come in saying, I don't want to come back for any adjustments. I want it to be perfect from the first day. Maybe no one's quite that extreme about it, but people just aren't sure what to expect. They don't want to hear any background noise, and they don't want to have to clean it or have any kind of maintenance. It's just kind of an unrealistic expectation. Hearing aids will significantly improve your hearing depending on the severity of the loss. And what I mean by that is some people have a mild hearing loss, and I tell them, you're going to get some improvement, but it's not going to be a night and day difference. A mild hearing loss usually sees a mild benefit from wearing hearing aids. Things are a little bit easier to hear, but it wasn't that bad in the first place. You're going to have better speech understanding. There will be some feedback, maybe, depending on the loss and the fitting, but it should be minimal. It shouldn't be excessive. If it's excessive, something's wrong, and I'd rather the person come back for some follow-up adjustments. You can expect that communication ability will be easier in a big variety of environments, but it won't be perfect. We can never expect perfect. Follow-up adjustments are often needed. I've maybe once or twice had someone come in for their first follow-up after getting new hearing aids and said, everything's great, I don't need to come back. That is pretty rare. Usually some adjustments are needed. And you can also expect to have improved speech understanding and background noise, but I would also expect some difficulty to remain, certainly depending on the environment. Many people with normal hearing have trouble in background noise, so it's reasonable to expect a person with hearing loss and hearing aids will still have some trouble, though it should be better. So it's really important to remember that hearing aids are a really important tool for improving communication, but they're only that. Hearing aids are a tool that we're using to improve your communication. It's really easy to get bogged down in the device and think, well, which is the best hearing aid? And really think about, well, this device does this and that device does that. At the end of the day, it's about communication, and it's not always about Oticon versus Phonak. Sometimes it's about, we need to teach your spouse not to yell at you from the other room, because it doesn't matter what brand you have if your communication partner is using poor communication strategies or habits. The hearing aid should be provided in the context of rehabilitation, and we shouldn't put so much emphasis just on the device, because hearing aids do not cure hearing loss. Really, underlying auditory processing difficulties will still remain. Hearing aids are helping, but all the sound is still being presented to that damaged cochlea, the damaged sensory organ. Remember that hearing aids are simply computers. They have to be programmed and verified by somebody, by a provider, for efficacy and safety. So essentially, you want to make sure the hearing aids are loud enough, but not too loud. And that has to be done by putting a little microphone in the ear to actually measure the sound coming from it. And if you've watched any of my other webinars, I talk about real ear measures all the time. So how the hearing aid is programmed matters, probably more than the brand itself. So your provider is really more important than the actual product. So while we move on talking about hearing aids from here on out and cochlear implants, who you're actually seeing to get this from matters more. So just things to keep in mind. This is a screenshot of a patient going through a hearing aid verification. So this is the procedure called real ear measures. He has a hearing aid on the ear with the sound going in, and then there's a little microphone tube inserted in the ear to take a measurement of the sound. That measurement is being recorded and shown and displayed on that screen so that I can see exactly how much sound he's hearing from each frequency. And so this is an example of the screenshot from what he's seeing. With the microphone in his ear, we're looking at here his low frequency to high frequency sound. And on this graph, soft sound's at the bottom, loud sound is at the top. What we're looking at for the hearing aid output is this orange shaded area. The blue line is his hearing loss. And so the line gets higher over in the high frequencies because he has more hearing loss in the high frequency region, just like most people with an age or noise-induced hearing loss. This output from the hearing aid falling under the blue line means that he's not hearing the sound at that frequency at all. And so essentially this hearing aid is an earplug for him. He's really not hearing anything from it in the range where he has his hearing loss. A better hearing aid would look like this. The fuchsia represents soft speech, and it's the bold line is the measurement of the output from his hearing aid. The green line is average conversational speech, and the blue line is louder speech. These little crosshairs are our prescriptive targets. So these are how loud each frequency should be for each level of sound, soft, average, and loud. This is a hearing aid that gets a gold star. This is a hearing aid that is matching this person's prescription. Why this is important is because not everyone uses real ear measures. Not even all audiologists use this procedure, and certainly hearing aid dealers do not use this procedure. This is a really simple way to verify that a hearing aid's actually working, and it can be done on anything. It can be done on traditional hearing aids or on OTC hearing aids. To look at, all we need is your hearing test and the device itself, and we put a microphone in the ear to check it. We'll move on. Oh, I know what I wanted to say. The reason I bring this up is because the people who do not run these measurements, they take a hearing aid from the shelf, they put the person's hearing loss in a computer, and the computer estimates the sound output as to what it should be. But we know because of resonant characteristics. So if you have a really big cavity versus a really small cavity, it affects what sound waves travel through, are amplified or attenuated. And so the size and shape of someone's ear canal can affect what sound leaves the hearing aid and actually reaches the eardrum. The estimations by the computer software are just that. They're estimates based on an average sized ear canal. I have never run this measurement on anyone, and it matched perfectly with the manufacturer's software's estimate of where it should be. It is almost always too soft. So this is something that really needs to be done when you get hearing aids. Otherwise, what are you buying? You don't know what you're getting if you don't actually measure it. When you wear hearing aids, it takes time to adapt to them. And here at the UNC HCC, we have typically a 6-week follow-up period with appointments at 2-week intervals in between. Because remember that a hearing aid is just a tool, and it's in the context of rehabilitation. And we call this oral rehabilitation, AURAL. So rehabilitation for the ear. If you're using the captioning, it's not captioning my letters very well, so I apologize for that. But we really need this period of time to adjust to the hearing aids and learn how to use them, because wearing hearing aids is a therapy process. Thinking about long-term care with hearing aids, what you can expect is every month or two, you'll want to clean the hearing aids, check for wax buildup on the earpiece, and keep them dry. At 6 to 12 months, you should have checkup appointments with your audiologist. So they will clean and check your hearing aids. They'll check your ears for wax buildup and clean your ears if needed. They'll change the small parts on the hearing aid and do any kind of troubleshooting that's necessary in that time. Every 2 to 3 years, we generally recommend having an updated hearing test. With age-related hearing loss, it's typically a very slow decline. So every 2 to 3 years is usually a good interval to check up on the hearing loss. And we can reprogram hearing aids if we need to. Hearing aids generally last about 5 to 7 years if they're kept clean and dry. So at the 5 to 7 year mark, most people are starting to consider updated technology. I never recommend upgrading a hearing aid just for the sake of it being new. You want to think about, is the current hearing aid still providing the right amount of amplification? And we would know that by having an updated hearing test and running the real ear measurements to check the output of the hearing aid. And are those devices still the most appropriate for your lifestyle or your listening needs? If someone's dexterity has become poor, or if they've lost their vision, they're probably not going to be very good at changing a small hearing aid battery once a week, and they may benefit more from a rechargeable model. So those are some of the things you think about when you're in the process of considering newer technology. So at this point, we started making this talk a little while ago, and Zach and I did, and we originally were not going to talk about OTC hearing aids in this talk. And then when the FDA published guidelines, we kind of thought we had to. So we're going to have a talk in November that goes really into a lot more detail about OTC. But just to address it here today, I did want to spend some time talking about it. So over-the-counter has now been classified officially as a new type of hearing aid. Really store-bought amplifying devices have been out for years, if not decades. They've been called PSAPs for a long time, or personal sound amplifying products. PSAPs are not FDA approved or regulated for treating hearing loss. They're marketed as hearing enhancers. So better for hearing the TV, better for hearing the birds, but not for treating hearing loss, though many people use them as such, of course. These PSAPs are usually fairly basic. They have presets, maybe volume setting 1, 2, and 3. They're not typically programmable with a bass, mid, treble type of equalizer. They may have some user controls depending on how advanced that amplification product is, like volume. They may have a noise suppression option with directional microphones. They're typically pretty rudimentary. So that's a PSAP. OTCs now, well, let me talk about traditional hearing aids first. So before OTCs came on the market, we had PSAPs that you could buy typically online or through mail order. And then we had hearing aids, which are FDA approved and regulated for the treatment of hearing loss. So they're medical devices. You have to have a license to be able to dispense these medical devices. They're programmable by computer software by someone who is licensed to do so. They have a wide range of advanced digital features and user controls. you may see a lot of marketing that says new digital hearing aid. All hearing aids have been digital for over 20 years now. But in the past, we had analog hearing aids that were not digital. So sometimes people still add the word digital to their marketing. Pretty much everything you're going to see now is digital. A hearing aid, a traditional hearing aid, must be fit and sold by a healthcare provider who's licensed to do so. And hearing aids are appropriate for both adults and children. PSAPs are not appropriate for children, nor are over-the-counter hearing aids. So this slide specifically is about a year old. So that's why it says it will be FDA regulated for mild to moderate hearing loss. But as of a few days ago, over-the-counter hearing aids are FDA approved for a perceived mild to moderate hearing loss. And they're only for adults also. So we'll go into some more detail. In 2017, there was legislation authorized by the FDA to create this new classification of hearing aids. Now, this is not traditional hearing aids sold in a store that you can go buy. This is a completely different type of device. The Over-the-Counter Hearing Aid Act ended up passing with the intent to improve access to hearing aids and improve affordability. In August, the final regulations were published and approved, as probably a lot of you know already. So this new class of hearing devices are designed for adults 18 and older with a perceived mild to moderate hearing loss. This tends to be the cohort of people who know they have hearing loss, but aren't really ready to do anything about it because it's not a big enough problem in their life. Maybe they're having trouble in one or two listening environments. Maybe the TV and background noise are the two most common, but it's not really bad enough to want to wear a hearing aid all day, every day. So these OTC devices are not traditional hearing aids, as I mentioned. They have unique guidelines and specifications for how they're to work. So some expectations for our OTC hearing aids. On the outside, they look really similar to a traditional or prescription-based hearing aid. They might look sleek like this brand from Lexi, or they might look really big and ugly and bulky like this less expensive one from who knows what brand. OTC hearing aids are programmable by the user, by the person who's wearing it, based on their preference. So it may be as simple as having a select presets. As I mentioned before, you may have volume setting 1, 2, or 3, and you pick which one sounds the best, and that's how you wear it. They may have additional preference controls like bass or treble manipulation. Lexi uses an app that you download, and it runs you through kind of a hearing test with the hearing aids in, and then it has a calibration based on that, and you can modify it to your liking, basically, after the fact. Most of these OTC hearing aids are an over-the-ear style with a tube that goes down into the ear. So even the Lexi brand, which looks pretty sleek, is a slim tube that sends the sound into the ear. If you're wearing traditional hearing aids, most of the time people are wearing RIC hearing aids, RIC. And these hearing aids are a small wire going into the ear instead. The OTCs companies will likely choose to use a tube because it's a lot easier to clean and it's less expensive to build. OTC hearing aids are intended to be worn part-time, kind of like reader eyeglasses. OTC hearing aids are not recommended for people with greater than a moderate hearing loss because they won't be able to achieve the appropriate audibility that they need for speech understanding. for a few reasons. There are output limits on the OTC hearing aids, but also if you turn it up very loud, you're gonna get whistling most likely, and you're gonna end up turning it down to combat the whistling. The OTC hearing aids do not have all the features of traditional hearing aids like phase inversion and phase cancellation to cancel out a feedback tone. And while OTC hearing aids can't be fine-tuned in the same way as traditional hearing aids, in other words, they can't be tuned really frequency by frequency based on the amount of hearing loss at each frequency, their output can be verified in relation to a person's hearing loss. So, like I mentioned before, we can do real ear measures on anything. And a consultation with an audiologist, if you have an OTC hearing aid, we can help you find the most appropriate preset for your hearing loss. For more information, Dr. Patricia Johnson of our clinic has written an excellent post for our website that is linked there. And I will leave this up for just a minute if anyone wants to take a picture of that link. You can also just search it on our website. And if you'd like the link, but you didn't get it, let me know in the chat box and I can paste it in there. It was also in the email blast that was sent out from us yesterday. So if you don't know where to start, regardless of where you are in your hearing journey, the best place to start is with a hearing test. Ideally with an audiologist and not with a hearing aid dealer or someone who's working in a retail setting. Because what if your hearing loss is due to wax impaction? What if it's due to a problem with the middle ear bones? What if it's due to a tumor growing on the nerve? You want to know these things before you go buy a hearing aid off the shelf. And so a hearing test is always the best place to start. Most insurance plans cover the testing that needs to be done by an audiologist. And if you already own traditional or over-the-counter hearing aids, you can always ask for a second opinion consultation. All we need is a hearing test and to run the real ear measurements to know if the hearing aids are appropriate for your loss. And we can give you some counseling about how to make them more appropriate. If you don't find benefit from an over-the-counter hearing aid, or if you know other people who have them and they say, they didn't work, so I just give up, don't be discouraged because the capabilities of that device may not have been appropriate for your specific needs. And if you're thinking about what's more appropriate for me, should I go with traditional prescription-based hearing aids or should I go with an over-the-counter? An important question to ask yourself is, do I want to be a patient or do I want to be a consumer? Do I need hearing aids 30 minutes a day when I go out to a restaurant, or do I need them more than half the day? And the answers to those questions may direct you to the level of care that you really need. So that was a lot. Last but not least, we're going to briefly talk about cochlear implants because they are a great treatment option for severe to profound hearing loss. I do have a separate webinar that I gave a few months ago on cochlear implants on the website. So we'll talk about this briefly today, and we'll also answer questions at the end. So a cochlear implant looks kind of like a hearing aid on the outside, but it has this coil transmitter that attaches to another part under the skin. So there are two pieces, the external and the internal. The external has your microphone that's picking up the sound. It has a power supply with a battery and a sound processor, sends the sound to the transmitter, which goes through the skin to a magnet on the other side, So this transmitter on the outside is removable. You take it off, you don't hear. You put it on its magnet, you can hear. The sound then gets transmitted through an electrode array that's inserted by an otologist or a surgeon who specializes in the ear. They do have off-the-ear speech processors as well. So I guess the other thing I want to talk about on the slide is that a cochlear implant is meant to replace the hair cells. So a hearing aid relies on there to be remaining hair cells in the inner ear to pick up the sound. But what if they're all wiped out? A hearing aid's not going to help. Instead, an electrode array is inserted into the cochlea, and it essentially lays on top of where the hair cells were. The electrode array sends pulses to the corresponding electrodes, and that stimulates the nerve directly underneath the hair cells. And that is how we hear electrically. So as of the end of 2019, this information is from the FDA, about over 700,000 cochlear implants have been implanted worldwide. And in the US, over 100,000 devices have been implanted in adults and 65,000 in children. So people with hearing loss, who are born with hearing loss, as long as they have an intact nerve, they can benefit from a cochlear implant. So there are lots of reasons why children are born without any hearing, and a cochlear implant can be the difference between hearing and not hearing and having to learn sign language. In adults who are what we call postlingually deafened, that means they've learned language when they were a child and now they've lost hearing as they got older for whatever reason. The cochlear implant now is sending a new type of signal to the brain via electrical pulses to the cochlea, and the brain learns over time to interpret that sound as speech or other sounds, any sound in our environment. The evaluation process is pretty thorough because you do have to go through a surgery to get this, so it needs to be thorough. The first step is usually a hearing test, and a doctor of audiology will review your hearing history. They'll test you with and without hearing aids. They'll test your speech understanding, also with and without hearing aids. They will go over the results with you and make appropriate recommendations based on the results. They should answer your questions as well as review information on cochlear implant technology if it's a cochlear implant evaluation specifically. There will also be a medical assessment. An ENT who specializes in the ears, called an otologist, will go over your health history background and your medications. If you're under the care of any other physicians like cardiology, they'll also want to consult with audiology since you have to go under general anesthesia. They will also order imaging to look at the anatomy of the ears to ensure that they can properly insert the implant. And the physician will answer any questions you have about the surgery, procedure, risks, and what to expect. Undergoing the implantation is typically an outpatient surgery. So most people go home the same day, though sometimes they'll stay overnight for observation, depending on their health history. Follow-up care is pretty extensive with cochlear implants because it's a totally different type of hearing. For adults, after your activation, you usually have a follow-up visit anywhere from between 6 to 8 within the first year, and then annual visits thereafter. There's a lot more visits at the beginning compared to as time goes on. There is a much longer adaptation period with cochlear implants compared to hearing aids because it's a different way to hear. Lately, there have been lots of advancements in cochlear implants. There are rechargeable options that have been out for a few years now, but there's certainly more within the last year or so. There are waterproof options, so you can get a casing that can completely cover it. Unlike hearing aids, which need an exposed speaker to send acoustic sound to the ear, the cochlear implant is transmitted via magnet on the outside of the skin. So you can completely cover it with a waterproof casing and swim with it. Cochlear implants are also compatible with smartphones. We have expanded criteria, which means that people with less severe hearing loss can now safely get a cochlear implant if they qualify for it. In the last few years, the FDA also approved cochlear implants for single-sided deafness, and this is thanks to a lot of research at UNC hospitals with the cochlear implant company MED-EL. At least a few years ago, MED-EL was the only company approved for single-sided deafness. I don't know if that's changed in the last few years, though. I don't work with cochlear implants at this clinic. So a cochlear implant would be superior to having a cross hearing aid for single-sided deafness because a cochlear implant would give you sound back to the ear that you can't wear a hearing aid on because it's got too much hearing loss. So having a hearing aid on one side and a cochlear implant on the other, for some people, is the only way to achieve binaural hearing. So there's a whole team that's a part of the cochlear implantation process, and it all starts really with the audiologist and the otologist, and they refer out as needed. But of course, you are the most important person on that team. So today we talked about types of hearing loss. We talked about that the hearing devices vary as to what treatment is recommended based on the type and severity of the loss. So a prescription-based hearing aid may be more appropriate, or an OTC may be a good option if you have a mild to moderate hearing loss. Cochlear implants are for more severe hearing losses. We didn't talk very much about bone-anchored hearing aids, but those are really for people with conductive or mixed hearing losses that sends the sound to the cochlea directly. So those are appropriate for kind of a mild to moderate range of conductive hearing loss. Education, counseling, and support services are extremely important in thinking about this concept of oral rehabilitation. So remember that it's not all about the hearing aid or the cochlear implant. It's also about knowing how to use your devices and how they're set up for you to know that you're getting the best rehabilitation possible. An audiologist's job is to help you navigate the available treatment options to pick the one that best matches your listening and lifestyle needs. And remember that the provider matters more than the product. When you're looking for hearing aids, ask the audiologist who you're with, or the hearing aid dealer, if you're at a retail chain, if they use real ear measures to program hearing aids routinely. Not just, oh yeah, I have that equipment, but I use it every time for every fitting. A traditional hearing aid's not always the best option for better hearing. Starting with a hearing test, or what we call an audiometric evaluation, a lifestyle assessment, and possibly a medical workup if needed, can help determine the best option for your hearing needs. So thank you for sticking with us. I know that took a while to get through everything. At this point, we are going to stop the recording for our YouTube viewers and go to questions from our live viewers. So if you're watching this on YouTube, please like this video and hit the subscribe button if you have not already, and we'll see you next time.